Welcome back to the Deep Dive. Today we are opening up a stack of some heavy hitters. We're talking Miller's anesthesia, Stolting, Morgan, and Mikhail, and especially focusing on long and short cases by Puneet Khanna.
The essentials.
Absolutely. And we are targeting a very, very specific listener today. If you're tuning in right now, there's a good chance you're a postgraduate student. Maybe you're just weeks away from your MD anesthesiology exams, perhaps even targeting the Gujarat University papers.
Or you're a junior resident who's just been posted in thoracic for the first time.
Exactly. Or maybe you're just, tired of looking like a deer in headlights when the thoracic surgeon looks over the drapes and asks for lung isolation.
It's a rite of passage, isn't it? Thoracic anesthesia is really where the rubber meets the road. It's where the physiology isn't just a concept in a book. It's staring you in the face on the monitor in real time.
And today we are dissecting two absolute beasts of the curriculum, transhiatal esophageectomy, or VHE, and video-assisted thoracoscopic surgery, also known as VATS. And these aren't just random surgeries we picked out of a hat. These are exam cornerstones.
Oh, absolutely. These are the topics that separate the pass from the honors, frankly. They're examiner favorites because they don't just test your ability to, push propofol or hang a bag of fluids.
Right.
They test your grasp of complex respiratory physiology, your pharmacology, especially regarding chemotherapeutic agents, your crisis management during a hemodynamic collapse, and your anatomical visualization all at once.
So it's a test of everything.
It is. If you get a long question on, say, anesthetic management of esophagectomy, you can't just ramble. You need a structured, examiner-approved answer.
And that is our mission today. We're going to try and convert that textbook density into high-yield, Viva-ready answers. We'll break down the HHE, then we'll move to VATs, and this is the crucial part. We'll compare them because that comparison is a classic Viva trap.
It really is. Let's get into it.
All right. Let's start right at the beginning. Part A, Introduction and Exam Framing. I'm in the exam hall. The external examiner looks over his glasses. He's probably tired. He's heard 10 students already. And he asks, "Doctor, in one sentence, what exactly are we dealing with here? How do I define transhiatal esophagectomy?"
Precision is absolutely key here. You need to give what I call the elevator pitch. You define transhiatal esophagectomy, or VHE, as a surgical procedure, usually palliative or curative for esophageal cancer.
Okay.
The defining feature, the phrase that must leave your mouth, is that it combines an abdominal and a cervical approach to remove the esophagus.
Right.
And this is the key bit. Crucially, avoiding a thoracotomy.
Avoiding the thoracotomy. That's the headline there.
It is. The whole point of the procedure when it was developed was to avoid cracking the chest. It relies on blunt dissection through the diaphragmatic hiatus. It was popularized specifically to avoid the massive morbidity associated with a thoracotomy. The pain, the respiratory failure, the long ICU stays.
But I'm guessing it's not that simple.
Well, as we'll discuss, avoiding the thoracotomy introduces a whole new and very unique set of problems for the anesthetist.
Okay, so then what about VATS? The same one-sentence definition.
VATS is video-assisted thoracoscopic surgery. You can define this as a minimally invasive thoracic surgery that uses small ports and a video camera rather than a large incision to perform procedures inside the chest.
Like what kind of procedures?
Oh, all sorts. Pulmonary resections, lobectomies, bullate excision, decortication, basically anything where you need to work on the lung or the pleura. And it's generally preferred over an open thoracotomy because it leads to decreased respiratory complications, less pain, and a much faster recovery for the patient.
So let's get to the heart of it. Why do examiners love these two specifically? Why not, a lap col or a hernia repair?
Because the margin for error is razor thin and they test completely different skill sets. With the HA, you're working in two body cavities at once, the abdomen and the neck. But the most critical part, the dissection of the mediastinum, is done blindly.
Blindly? That sounds terrifying.
It is. You are manipulating tissue right next to the heart and the great vessels without directly seeing them. This causes massive, and I mean massive, hemodynamic shifts. It tests your ability to anticipate and treat cardiovascular collapse on a beat-to-beat basis.
And VATS, what's the core challenge there?
VATS brings in the ultimate respiratory challenge, the whole concept of one lung ventilation, or OLV. You are deliberately collapsing a lung, which creates a huge right-to-left shunt in the circulation.
Right, a VQ mismatch by design.
Exactly, by design. And you have to manage the resulting hypoxia while the surgeon is working. It tests your respiratory physiology knowledge to an absolute limit.
So one is a hemodynamic test, the other is a respiratory test. It really does sound like a perfect storm for an exam question.
It is, and you'll see it in every format. In the exam pattern, you'll often see a 10 or 20 mark theory question like, describe the anesthetic management of a patient for transhiatal esophagectomy.
The long question.
The classic long question. And in the Viva, they might hand you a double lumen tube and say, show me how you'd place this, or they'll give you a scenario. Your patient desaturates to 80% during OLV. Talk me through your management. You need to be ready for both the written structure and that verbal defense.
Okay, that sets the stage perfectly. Let's tackle the first beast then. Transhiatal esophagectomy. Part B. We'll start with Section 2. A surgical overview. I want to understand the surgery before we try to anesthetize it. You mentioned blind dissection. Let's break that down.
You absolutely have to. You can't anesthetize for a surgery you don't understand. So for the E, the surgeon starts with a laparotomy incision, a big cut on the abdomen.
Okay.
The goal here is to mobilize the stomach. They have to free it up from its attachments and blood supply because that stomach is going to become the new esophagus. It's pulled up into the chest to replace what's been removed, call it the gastric conduit.
Right, I've heard that term.
Simultaneously, or maybe sequentially, a second team will make a cervical incision in the neck to access the upper part of the esophagus.
So you've got access from the top and the bottom. What about the part in the middle, the thoracic esophagus?
And that's the exam core concept. That's the scary part. The dissection of the thoracic esophagus is done blindly. The surgeon reaches up from the abdomen, through the hiatus in the diaphragm, and down from the neck. They're essentially stripping the esophagus away from the aorta, the trachea, and the pericardium using their fingers and some blunt instruments.
I'm just picturing a hand reaching up behind someone's heart.
That is exactly what it is. For a few minutes during the procedure, the surgeon's hand is physically inside the mediastinum, right behind the left atrium. And that is the moment where the anesthetist truly earns their money.
Wow. Okay. So before we even get to that point on the table, let's go back to the pre-op clinic. Section 3, preoperative assessment. This feels critical for the long case. A patient walks in with esophageal cancer. What are the red flags we're looking for?
This is where a book like Long and Short Cases in Anesthesiology by Khanna becomes your Bible. You have to look at the consequences of both the disease itself and the treatment they've received.
Okay, so where do we start?
First, nutritional status. It's almost always terrible. These patients have dysphagia. They haven't eaten a solid meal in months. They are often cachectic, severely malnourished, and have profound hypoalbuminemia.
Why does albumin matter so much to us? I know it binds drugs, but is that the main worry?
The drug binding is important, but it's actually bigger than that. Sure, low albumin changes the free fraction of drugs like thiopentone and your muscle relaxants, making them much more potent. You'll need less drug.
Right.
But physiologically, albumin is what maintains oncotic pressure. It keeps fluid inside the blood vessels. If a patient's albumin is low, let's say below 2.5 or 3 grams per deciliter fluid, just leaks out of the vessels and into the tissues.
So they're prone to edema.
Terribly prone. These patients are incredibly susceptible to pulmonary edema and, crucially, swelling at the site of the anastomosis.
So a normal amount of fluid for a healthy patient might actually drown a hypoalbuminemic patient.
That's a perfect way to put it. You could drown them. Plus, poor nutrition means poor wound healing, which is an absolute disaster for the anastomosis. If that new connection in the neck leaks, it's a major, often fatal complication.
Okay, nutrition is a huge red flag. What's next?
The big one. The one examiners hunt for is the patient's chemotherapy history.
Right, the specific toxic effects of the drugs. Which ones are we most worried about?
You need to know 3 by heart: Bleomycin, Doxorubicin, and cisplatin. You need to be able to recite the specific complications for each one.
Okay, let's walk through them. Bleomycin.
Bleomycin means lungs. It causes pulmonary fibrosis. The mechanism is that it creates free radicals in the lung tissue, leading to inflammation and scarring.
And what's the key for the anesthetist?
The key is that high concentrations of oxygen facilitate this damage. It's like pouring fuel on the fire. So if a patient has received bleomycin, you are terrified of oxygen toxicity.
What investigations would you want?
You absolutely need pulmonary function tests, or PFTs. And specifically, you're looking at the DLCO, the diffusing capacity of the lungs for carbon monoxide. That tells you how well gas is getting across the alveolar membrane. If it's low, that's a bad sign.
And intraoperatively, how does it change your management?
You have to limit your FiO2. You do not just blast them with 100% oxygen because you're nervous. You aim for the lowest FiO2 that gives you a safe saturation, say, maintain your SpO2 above 92%, but don't aim for 100%. And you have to be extra, extra careful with fluids because their lungs are already primed for edema.
Okay, that bleomycin. What about doxorubicin?
Doxorubicin is the red devil. It causes cardiotoxicity, specifically a dose-dependent dilated cardiomyopathy.
Dose-dependent?
Yes. The risk skyrockets if they've had a cumulative dose over about 550 milligrams per square meter. Before you take this patient to theater, you need a 2D echocardiogram to check their ejection fraction. If their EF is below 45%, they might not tolerate the huge hemodynamic swings of the surgery.
And the third one, cisplatin.
Cisplatin is nephrotoxic. It directly damages the renal tubules, so you need to check their creatinine and urea. And you have to be very careful with drugs post-op specifically. You want to avoid NSAIDs if the renal function is even borderline.
Makes sense. Okay, we've covered nutrition, chemo. What about the aspiration risk?
The aspiration risk is 100%. There is no debate. The esophagus is obstructed. So you have a proximal pouch that's full of saliva, secretions, maybe food debris that hasn't passed for days.
So even if they've been fasted for 12 hours.
That pouch is not empty. You must assume a full stomach. And that assumption dictates your entire induction strategy.
We'll get to that. One last thing on pre-op. Other comorbidities?
Well, think about the patient population for esophageal cancer. They are often elderly, and they're almost always heavy smokers and drinkers. So you need to look for COPD, bronchiectasis, coronary artery disease. A thorough systems review is non-negotiable.
Okay, let's move into the operating theater, section 4. Physiological challenges during the surgery itself. We touch on the blind dissection. Let's dig deeper. What exactly is happening physiologically when the surgeon puts their hand through the hiatus?
This is exam gold right here. This is the core of the challenge. When the surgeon dissects through the hiatus, they are physically encroaching on the mediastinum. Hemodynamically, the first thing you get is direct cardiac compression.
The hand is literally squashing the heart.
It's pushing on the left atrium. This immediately reduces venous return and therefore stroke volume instantly.
So on the monitor, you'd see the arterial line trace just dampen.
You'll see it dampen or you'll see it flatline sometimes. The mean arterial pressure, the MAP, drops like a stone. At the exact same time, the manipulation can stimulate the vagus nerve, which can cause profound bradycardia.
So hypotension and bradycardia.
Or, just by irritating the myocardium directly, you can trigger tachyarrhythmias, ventricular ectopics, runs of VT, AF. It's an incredibly volatile mix.
Hypotension plus arrhythmias. It's a nightmare.
It is, and the respiratory challenge is just as real. The trachea is sitting right there in the superior mediastinum. The surgeon, dissecting blindly, can accidentally compress the trachea.
And you'd see what?
You'd see your peak airway pressures on the ventilator spike, and your delivered tidal volume would just disappear. The ventilator is alarming. You can't push air in.
Or worse.
Or worse, they can actually tear the membranous posterior wall of the trachea. It's rare, but catastrophic. If you suddenly see a massive air leak that you can't fix, or surgical emphysema puffing up the patient's neck like a balloon, you have to think tracheal injury.
And even though this whole procedure is designed to avoid opening the chest, the pleura is still at risk, right?
Absolutely correct. The parietal pleura is paper thin. During that blunt dissection, it is incredibly easy to tear it. Suddenly, you have a pneumothorax and a closed chest.
And since we're using positive pressure ventilation,
it can quickly become a tension pneumothorax. The patient will crash, hypotension, tachycardia, desaturation. You need to be watching the airway pressures and listening for air entry like a hawk.
This is where that idea from Miller's comes in, right? The inverse correlation.
Yes. They mention that perioperative mortality is inversely correlated with surgical volume. What that means is experience matters. A center that does hundreds of these has much better outcomes than one that does 2 a year because the whole team surgeons and anesthetists knows how to anticipate and manage these crises.
Okay, so let's build the anesthetic plan. We're moving to section 5, intraoperative anesthetic management. Let's start with induction.
Airway first. And as we said, because of the obstruction and the pouch, a rapid sequence induction, or RSI, is absolutely mandatory.
No question.
No question. Long and short cases is very clear on this. You pre-oxygenate thoroughly, you apply cricoid pressure, and even though its efficacy is debated in the literature, for the exam, you say you do it, and you absolutely do not mask ventilate before you intubate.
What kind of tube are we using? A standard endotracheal tube.
Usually a standard single lumen tube is sufficient for a tracheal esophagectomy because, again, we aren't planning on opening the chest. But you need to secure it extremely well. With tape, with a tube tie, whatever your method is. The surgeon is going to be working in the neck, pulling and retracting on tissues right next to the trachea. Accidental extubation during the cervical part of the procedure is a real and dangerous risk.
Is there ever a case for using a double lumen tube in the HE?
That's a great nuance to bring up in an exam. The answer is yes, sometimes. If the surgeon anticipates very difficult exposure high in the mediastinum, or, more commonly, if a large pleural tear occurs that prevents you from ventilating the patient effectively, you might need to swap out your single lumen tube for a DLT to isolate that lung, but it's not the default plan.
So the default answer is single lumen tube, RSI.
Correct.
Okay, 2's in. Let's talk about monitoring. I'm assuming we need a little more than a non-invasive blood pressure cuff?
Oh, absolutely. Invasive arterial blood pressure is mandatory. You simply cannot manage the wild swings from mediastinal manipulation with a cuff that's cycling every 3 or 5 minutes. You need beat-to-beat monitoring.
Where do you place the art line? Does it matter?
It can, yeah. Usually the radial artery is fine. But you have to think about the anatomy. If the surgeon is dissecting high in the thorax, they might compress the subclavian artery on one side.
Ah.
So if your art line is on the left and they compress the left subclavian, you lose your trace. Your monitor reads 40/20. It doesn't mean the heart has stopped, but it's terrifying if you aren't expecting it. For that reason, some people prefer the right radial artery, as the right subclavian is a little less vulnerable.
What about CVP? Central line.
A central line is essential for giving vasopressors. As for CVP monitoring, it's a bit controversial and often considered outdated for guiding fluid therapy, but you'll probably place one. Miller would suggest that for very high-risk cardiac patients, you might even consider a PA catheter, but that's becoming increasingly rare.
Okay, let's get to the big one, fluid management. This feels like the most controversial and important part. The old school thinking was just fill them up, right?
That thinking has changed completely. And for your exam, and more importantly for your patient, the answer is a restrictive fluid strategy. This is a critical high-yield point. Miller emphasizes this repeatedly.
Why so restrictive? What's the danger of giving fluid?
2 massive reasons. The first is what we call wet lungs. As we discussed, these patients are often hypoalbuminemic and prone to leaky capillaries. They're already at high risk for acute lung injury, ALI, and ARDS. If you overload them with crystalloid, you are basically guaranteeing post-op respiratory failure.
And second reason.
The anastomosis. The stomach is being pulled up into the neck, and its venous drainage is now compromised. It's not as good as it was in the abdomen. If you overload the patient with fluid, you get edema at that anastomotic site. Swollen, boggy tissues don't heal, they fall apart, they leak.
So if the blood pressure drops during that blind dissection, we don't just reach for the fluid bag and open it wide.
Absolutely not. That's the trap. If the patient is normovolemic, meaning you haven't had massive blood loss, you use vasopressors. A neatly titrated infusion of noradrenaline or phenylephrine is far better than 2 liters of saline. You treat the cause, which is often mechanical compression or vasodilation, rather than just blindly filling the tank.
Okay, that's a huge take-home point. What about temperature?
Active warming is crucial. The abdomen is open from the xiphisternum to the pubis. The neck is open. Heat loss is absolutely massive. Hypothermia causes coagulopathy, which you cannot afford in a surgery with potential for major bleeding. Use forced air warmers, fluid warmers, and keep the ambient temperature in the OR as high as you can tolerate.
All right. Section 6, complications. Let's role play the nightmare scenarios. The examiner looks at you and says, you're in the maintenance phase of ADE. The surgeon is dissecting in the mediastinum. Suddenly, the BP drops to 50/30. Talk me through your actions.
Step 1, and this is always step 1, communicate. You have to say clearly and calmly to the surgeon, please stop dissection for a moment, I've lost the blood pressure. Usually, the hypotension is purely mechanical compression. The surgeon removes their hand, the heart fills, and BP bounces right back up. 90% of the time, that's the fix.
And if it doesn't? If they stop and the BP stays low?
Then you have to run your differential diagnosis out loud for the examiner. Could this be massive hemorrhage? The azygos vein or even the aorta could be torn. Is it a tension pneumothorax? I'd immediately check for equal air entry and look at my airway pressures. Is it an arrhythmia? I'd look at the ECG. Is it anaphylaxis to a drug I just gave?
Okay, let's take another one. The tracheobronchial injury. How do I spot that before it's too late?
The first sign is on the ventilator. You'll see a sudden, persistent loss of your delivered tidal volume. The bellows on the machine just stop moving up and down as much. You might see the end tidal CO2 trace become erratic or disappear entirely because you aren't actually ventilating the lungs effectively anymore.
And clinically, on the patient.
Clinically, you might see the neck and upper chest start puffing up with air. That's subcutaneous emphysema. That's a cardinal sign.
What's the immediate fix?
First, put the FiO2 to 100%. Second, notify the surgeon immediately. If you suspect the tears in the trachea, your best move is to try and advance the endotracheal tube past the tear using a bronchoscope if you can. This effectively bridges the gap and lets you ventilate again.
And if it's a huge tear?
If it's a big tear, you're in a real crisis. You might need to go on cardiopulmonary bypass or have the surgeon attempt an immediate suture repair while you try to hold ventilation. It's a can't intubate, can't ventilate scenario in the middle of the chest.
Okay. The surgery is finally done. We're in section 7, post-op management. The big question, do we wake them up on the table or send them to the ICU ventilated?
The modern trend, which is supported by Miller, is for early extubation if the patient is AWAC. That's an easy acronym to remember. Alert, warm, and comfortable.
Why the push for early extubation?
You want to avoid positive pressure ventilation if possible. Positive pressure puts stress on that new intrathoracic anastomosis and can potentially increase the risk of a leak. Spontaneous breathing is more physiological.
But regardless of extubation, they still go to the ICU.
Oh, always, no question. They need intensive, one-to-one nursing and invasive monitoring for at least 24 to 48 hours. You have to watch for respiratory failure. ARDS occurs in about 15% of these cases.
And the really dreaded complication.
The anastomotic leak. This is what can kill the patient a week after a successful surgery. It usually presents a bit later around days 3 to 7 with signs of sepsis, fever, and mediastinitis. It carries a very high mortality rate. Our job in the perioperative period is to maintain hemodynamic stability and perfusion to give that graft the best possible chance to heal.
That is an incredibly comprehensive look at the HE. Let's switch gears completely now. We're moving to Part C, video-assisted thoracoscopic surgery, VATS.
Right. A different beast entirely. Here we are definitely deliberately in the chest.
Okay, Section 8, surgical overview. How does VATS actually differ from the old-school open thoracotomy?
Well, the principle is that it's minimally invasive. Instead of a huge posterolateral thoracotomy incision, which involves spreading the ribs, often fracturing them and crushing the intercostal nerves, the surgeon uses 2, 3, maybe 4 small ports.
Keyhole surgery for the chest.
That's a good way to think of it. They insert a camera through one port and their instruments through the others. It's used for all sorts of things: lobectomies, wedge resections, decortication for emphysema.
Anesthetically, does minimally invasive for the surgeon mean easier for us?
Absolutely not. In many ways, it's harder. In an open case, if there's bleeding, the surgeon can just put their hand in and apply pressure. In VATS, they have very limited control of major bleeding.
And the view.
And crucially, their view is everything. They need the lung on the side they're operating on to be completely down, collapsed, deflated. In an open thoracotomy, they can physically pack the lung away with a sponge. In VATS, if the lung doesn't collapse properly, they simply can't see anything. The entire responsibility for providing surgical exposure falls on the anesthetist.
Miller makes an interesting point here about which patients are good candidates.
Yes. It's a bit counterintuitive, but patients with significant underlying lung disease like severe COPD often tolerate a VATS procedure better than an open one.
Why is that?
Because there's so much less pain and less destruction of the chest wall mechanics. After a VATS, they can still take a deep breath and cough effectively. After an open thoracotomy, they can't, and that leads to retained secretions and pneumonia. But, and it's a big but, the intraoperative management for those fragile patients is extremely demanding.
Let's look at that. Pre-op for VATS, Section 9. How do we decide if a patient can even tolerate having a piece of their lung removed? We can't just take out a lobe if they don't have the reserve to live with what's left.
Correct. For this, you need to assess what Miller calls the three-legged stool of respiratory function. It's a great way to frame it for an exam answer.
Okay, what's leg number 1?
Leg 1 is lung mechanical function. This is basic spirometry. Can the patient physically move air in and out? We look at the FEV1, the forced expiratory volume, in 1 second. If their predicted postoperative FEV1 is going to be less than 40%, they're considered high risk.
And leg 2?
Leg 2 is parenchymal function. This asks, how well does the lung that's there actually work? How well does it exchange gas? This is where we look at the DLCO and the arterial blood gas. If they're already hypercarbic, with a PCO2 over 45, or hypoxic at rest on room air, that's a very bad sign.
And the final leg of the stool.
Leg 3 is cardiopulmonary reserve. This looks at the interaction of the heart and lungs under stress. Can the whole system handle the insult of surgery? The gold standard test here is a formal cardiopulmonary exercise test, or CP, to measure their VO2 max. If it's less than 15 millipule-Gemin, mortality shoots way up.
But most hospitals don't have CP testing readily available. Is there a bedside hack for this?
There is, and it's a great thing to mention, the stair climbing test. It's simple, but it's been validated. The question is, can the patient climb 2 flights of stairs without stopping? If the answer is yes, they likely have the reserve to tolerate a lobectomy.
And for a pneumonectomy?
If they can climb 5 flights, they can probably tolerate a pneumonectomy. If they can't even climb 1 flight without getting breathless, they are very high risk, and you might need to reconsider non-surgical options.
And for VATS specifically, we also need to assess the airway with a particular piece of equipment in mind, don't we?
Absolutely. You have to assess the airway specifically for placing a double lumen tube, or DLT. These things are bulky, they're rigid, and they have a strange pre-formed curve. You need to check mouth opening. You probably need at least an extra centimeter compared to placing a normal tube. You check their neck mobility, and you look at their teeth. A DLT can very easily chip or dislodge a loose incisor.
Okay, section 10, airway management. This is the big technical skill check. How do we actually achieve that lung isolation the surgeon needs?
The gold standard for most adults is the left-sided double lumen tube.
Okay, stop right there. That's a classic point of confusion. Why left-sided? If we're operating on the left lung, shouldn't we be putting the tube into the right bronchus to ventilate it?
You would think so, but no. The anatomy dictates our choice. The right main bronchus is very short. It's only about 1.5 to 2 centimeters long before the bronchus to the right upper lobe takes off at a sharp angle.
That's it.
If you try to put a DLT in the right side, the bronchial cuff can very easily slide a little too far and block that upper lobe orifice. Or if it's not far enough, the cuff will herniate back into the trachea. The margin for error is tiny.
And the left bronchus is different.
The left main bronchus is much longer and more accommodating. It's about 4 to 5 centimeters long. You have plenty of room to park the bronchial cuff securely without blocking anything. So whether we are operating on the right lung or the left lung, we almost always use a left-sided DLT. We just clamp the appropriate lumen to deflate the lung we want down.
Are there any exceptions to that rule?
Only really if there's a physical reason you can't use the left bronchus, like a tumor obstructing it or a huge thoracic aortic aneurysm compressing it. In that rare case, you must use a right-sided DLT, but you have to be extremely skilled and use a fiber optic scope to position it without occluding that right upper lobe.
How do we size these things? They look like garden hoses.
Yeah, they're big. Sizing is based on height and gender, not really on weight. For most adult males, a 39 or 41 French is standard. For adult females, a 35 or 37 French. For smaller people, say under 160 centimeters, you might go down to a 32 or even a 28 French. The goal is for the tube to pass the glottis easily, but be large enough that the bronchial cuff can seal the bronchus without being overinflated.
What if we can't place a DLT? Maybe the patient has a known difficult airway, or they already have a tracheostomy. What's our backup plan?
Then you use a bronchial blocker. This is essentially a long, thin catheter with a balloon on the end. You pass it through a standard single lumen tube or sometimes alongside it. You then use a fiber optic scope to guide the blocker into the specific bronchus you want to block, inflate the balloon, and seal it off. It's a fantastic backup skill to have.
Okay, the tube is in. The examiner leans forward and asks, "Doctor, how do you confirm the position of your double lumen tube?"
The first words out of your mouth should not be auscultation. I mean, yes, of course you listen with your stethoscope, but it is notoriously inaccurate. The correct, exam-winning answer is fiber optic bronchoscopy.
Every single time.
Every single time. You must visualize the anatomy. You look down the tracheal lumen first, and you should see the carina. Then you look down the bronchial lumen, and you should see the blue bronchial cuff just below the carina, sitting nicely in the left main bronchus. Morgan and Miller both insist on this. Blind placement is not the standard of care anymore.
Got it. Section 11, intraoperative management. The lung is down. We're now ventilating only one lung. What should our ventilator settings look like?
We must use a protective lung ventilation strategy. You have to remember, you're asking one lung to do the work of 2, but you cannot just double the volume or the pressure, or you will injure that good lung.
So what are the numbers?
First, tidal volume. Keep it low. 4 to 6 milliliters per kilogram of ideal body weight. Do not use the patient's actual weight, especially if they are obese. Second, PEEP. Positive end expiratory pressure is absolutely crucial. You apply PEEP, usually around 5 to 10 centimeters of water, to the ventilated lung to keep it from collapsing at the end of expiration. And third, respiratory rate. You may need to increase it slightly to maintain a normal CO2, although a bit of permissive hypercapnia is often tolerated.
Now here it is, the classic inevitable VIVAS scenario. Doctor, you have initiated one lung ventilation. 5 minutes later, the patient's oxygen saturation drops to 85%. What do you do?
This is a drill. You have to have a structured algorithm in your head. Do not panic and do not just say, I'll increase the oxygen.
So what's step one?
Step one, immediately increase the FiO2 to 100%. That buys you time.
Check the tube position. This is the most common cause of sudden hypoxia. The patient was turned from supine to lateral. The surgeon leaned on the chest. The tube is moved. The quickest way to check is to stick the fiber optic scope back in. Is the cuff still where it's supposed to be?
Suction. Make sure both lumens are clear of secretions.
Check hemodynamics. Is the cardiac output okay? Low cardiac output or severe hypotension will worsen the shunt.
Okay, we've done all that, but the sats are still stubbornly low. What's next?
Step 5. This is the high-yield answer. You apply CPAP to the non-ventilated lung. You attach a special circuit and apply a small amount of continuous positive airway pressure, something like 2 to 5 centimeters of water, to the collapsed operative lung.
But wait, won't that inflate the lung and completely ruin the surgeon's view?
That's the key. At only 2 to 5 centimeters of water, it doesn't really inflate the lung in a way that bothers the surgeon. It barely distends it. But it's just enough pressure to recruit some of those collapsed alveoli, allowing them to participate in gas exchange. It reduces the shunt significantly. It's often the single most effective maneuver.
And if even that fails?
Step 6. You can try increasing the PEEP on the ventilated lung, maybe go from 5 up to 8 or 10. You're trying to optimize the good lung as much as possible.
If the patient is still crashing, you have to communicate with the surgeon. You tell them you need to reinflate the operative lung, even if it's just for a few breaths. Safety comes first. As the saying goes, 2 lungs are better than 1 dead patient.
Can you just quickly explain the core physiology there? Why does the saturation drop so dramatically in the first place?
It's all a problem of shape. In a normal, healthy person, blood flow or perfusion matches ventilation. V matches Q. When you deliberately collapse one lung, you are still sending about 40 to 50% of the cardiac output to that lung, but it's getting 0 oxygen. That deoxygenated blood just goes straight from the right side of the heart to the left side and mixes with the oxygenated blood from the good lung, dragging the overall saturation down.
But the body has a natural defense mechanism for this.
That's right. It does. It's called HPV, hypoxic pulmonary vasoconstriction. It's a brilliant reflex. The pulmonary blood vessels in the hypoxic, collapsed lung sense a low oxygen and automatically constrict. This diverts blood away from the bad lung and toward the good, ventilated lung. This clever mechanism reduces the shunt from a potential 50% down to a more manageable 20–25%.
Does our anesthetic interfere with HPV? That's a favorite pharmacology question.
It is, and the answer is yes, but maybe not as much as we used to think. The volatile anesthetics sevoflurane, desclurane, isoflurane do inhibit HPV in a dose-dependent manner. Theoretically, they could make the shunt worse.
So should we avoid them?
Not necessarily. Miller states that at concentrations of less than 1 mSc, this inhibition is clinically insignificant, so using low-dose gas is generally fine. What you really want to avoid are potent vasodilators like nitroglycerin or sodium nitroprusside, which will completely abolish HPV and cause a massive, profound drop in saturation.
What about using propofol, a TIVA technique?
Propofol, for TIVA, does not inhibit HPV. So, theoretically, it might be a better choice for maintaining oxygenation in a very fragile patient, but in everyday practice, a balanced technique with low-dose volatile is perfectly acceptable.
Okay, let's move to section 12. Hemodynamic and respiratory changes. We've got the patient in the lateral decubitus position. What does that position itself do to the physiology?
It's a classic VQ problem. Gravity becomes your friend and your enemy. In the lateral position, gravity naturally pulls more blood flow to the dependent or bottom lung. Since that's the lung we're ventilating, that's actually a good thing. VQ matching is preserved reasonably well. The blood goes where the air is.
But there's a downside.
But the downside is that the weight of the mediastinum, the heart, and all the abdominal contents pushing up on the diaphragm, all of that squashes that dependent lung. It promotes atelectasis in the very lung you're relying on. That's why PEEP is so important, to act as a pneumatic stent to keep those airways open.
What about CO2 insufflation? Do surgeons ever use gas to inflate the chest like they do in laparoscopy?
Yes, sometimes in VATS and almost always in robotic thoracic surgery, they will insufflate CO2 into the chest to create more space and push the diaphragm down.
And what are the consequences for us?
Well, it increases the intrathoracic pressure. This can compress the superior vena cava, reducing venous return and causing hypotension. And secondly, you can get significant hypercarbia because CO2 is absorbed very rapidly across the pleural surface. You'll see your end tidal, CO2 climbing, and you may need to increase your minute ventilation to wash it out.
Okay, that covers the intra-op phase of VATS. Let's move to Part D, postoperative analgesia and ICU care, Section 13. Thoracic surgery is notoriously painful.
It is among the most painful surgical incisions, and that pain is dangerous. If it hurts to breathe, the patient simply won't take deep breaths. They'll splint, they get atelectasis, they retain secretions, and they develop pneumonia. So providing excellent pain relief is not just for comfort, it's a therapeutic intervention to prevent respiratory failure.
So what's the gold standard?
The historical gold standard, especially for an open thoracotomy, is thoracic epidural analgesia, TEA.
Why is an epidural so good for this?
It provides dense segmental analgesia right where you need it, and it also blocks the sympathetic outflow, which reduces the surgical stress response. It's fantastic for improving pulmonary mechanics and allowing the patient to cough.
But for VATS, with just a few small ports, do we really need an epidural?
That's a great question. Probably not. An epidural has its own risks: hypotension, urinary retention, the rare but devastating risk of an epidural hematoma. For VATS, the field is definitely moving toward regional blocks like the paravertebral block, PVB, or the erector spinae plane, ESP block.
And are they as good?
Kaushik and Miller both highlight this. A paravertebral block, especially if a catheter is placed for a continuous infusion, can be just as effective as an epidural for the site-specific pain of VTS, but with far fewer side effects like hypotension.
What about systemic drugs? Just using an opioid PCA?
You always use a multimodal approach, but we try to minimize the opioids. So you'll use paracetamol, maybe NSAIDs if the patient's renal function is okay, and perhaps gabapentinoids. We really want to avoid high doses of opioids because they cause respiratory depression, which is the last thing we want in a thoracic surgery patient.
Section 14. Post-op complications. What are the big red flags we're looking for in the recovery room or the ICU?
Respiratory failure is always number one. You have to be vigilant for atelectasis turning into pneumonia. Another big one is nerve injuries. During the dissection, it's possible to injure the recurrent laryngeal nerve, which would cause hoarseness and a risk of aspiration.
And the phrenic nerves.
Or the phrenic nerve. If the phrenic nerve is zapped, that half of the diaphragm becomes paralyzed and moves, paradoxically. It moves up when you breathe in instead of down. That can make weaning from the ventilator incredibly difficult.
And what about the heart after thoracic surgery?
Atrial fibrillation. It's so common we almost call it the thoracic surgery sign. It happens in 10–20% of cases, especially in elderly patients. It's thought to be triggered by a combination of right atrial stretch during the surgery, systemic inflammation, and a catecholamine surge. You need to be proactive, correct electrolytes, especially keeping the magnesium level high, and be ready to control the heart rate with beta blockers or diltiazem.
Okay, fantastic. Let's move to the final part, Part E, comparison and exam integration. This is where we bring it all together for that long question, or VIVA. Section 15, the examiner asks, Doctor, compare and contrast the primary anesthetic concerns for a transhiatal esophagectomy versus a VTS lobectomy. How do I structure that answer so I don't just ramble?
You create a mental table, use headings. This shows the examiner you have a structured thought process.
Okay, let's build it. Row 1, the surgical approach.
For the ETE, it's an abdominal and a neck approach, avoiding the thorax. For VATS, it's a purely thoracic approach, usually in the lateral position.
Okay, row 2, the primary challenge.
For the ATE, the primary challenge is hemodynamic. It's about managing the cardiovascular collapse from direct cardiac compression. For VATS, the primary challenge is respiratory. It's all about managing hypoxia during one lung ventilation.
Row 3, airway management.
For DATS, the key is managing the high aspiration risk, so it demands an RSI, but you usually only need a standard single lumen tube. For VATS, aspiration risk is lower, but you absolutely need lung isolation, so a double lumen tube is the default.
Row 4, fluid management.
Both require a restrictive strategy, but you'd emphasize that VA is exquisitely sensitive to fluid overload because of the risk to the lungs and, critically, the anastomosis.
And row 5, postoperative pain.
VATS is significantly less painful, and it's often well managed with regional blocks like a PVB. D involves a major laparotomy, so the pain is more severe, and a thoracic epidural is often the better choice.
That's a perfect, clean framework. Okay, section 16, common exam questions and Viva traps. Let's do a rapid-fire drill. What are the common mistakes students make?
Trap 1. Underestimating the aspiration risk in esophageal cancer. Students often forget that an esophageal obstruction is not the same as a gastric obstruction. It's a static pouch of fluid. The correct answer you need to give is always assume a full stomach. RSI is non-negotiable.
Okay. Trap 2, panicked management of hypoxia during OLV.
Right, students just jump to 100% O2, or they immediately suggest clamping the pulmonary artery, which is a huge surgical step. The correct answer is to be systematic. Your first thought and your first action after increasing FiO2 must be to check the tube position with the bronchoscope. That is the most common cause.
And trap 3, fluid management in DHE.
Students hear hypotension, and their reflex is to give a fluid bolus. The correct answer for hypertension during mediastinal dissection is to first ask the surgeon to pause, and second, to use vasopressors if the patient is euvolemic. Protect the lungs and the anastomosis at all costs.
Perfect. Section 17, diagrams and exam presentation. I'm in the written paper and I want to score extra marks. What can I draw?
Diagrams are a fantastic way to stand out. First, you can draw the anatomy of a correctly placed left-sided DLT. Draw the trachea, the carina, the right and left main stem bronchi, and show the tube with the blue bronchial cuff sitting neatly in the left bronchus. Label the key parts and maybe even the average distances.
What else?
Second, for a patient with an esophageal mass, you could draw flow volume loops. A large mediastinal mass can cause either extrathoracic or intrathoracic airway obstruction. You could draw the classic truncated loop for a variable obstruction or the box-like loop for a fixed obstruction. That shows a deep understanding of physiology.
And for a management question?
Draw an algorithm. The hypoxia during OLV algorithm we just discussed is perfect for this. A clear flowchart with boxes and arrows is worth an entire page of dense text.
This is all fantastic. Let's wrap it up. Section 18, summary and exam conclusion. Professor, give us the golden rules to close this out, the take-home points for that final night of revision.
Okay, here we go.
Optimize the patient pre-op. You have to address malnutrition and investigate for chemotoxicity before you even think about anesthesia.
Secure the airway, always. That means RSI for VHE and a fiber optically verified DLT for VATS.
Respect the core physiology. Anticipate and be ready for hypotension in the HE. Anticipate and have a plan for hypoxia in VATS. 4. Restrict fluids judiciously. Do not drown the patient's lungs or their anastomosis. Use vasopressors.
Aggressive, multimodal pain control is non-negotiable. It's not just for comfort, it's for respiratory protection. Use epidurals or regional blocks. And 6, I'll borrow from Miller's, don't burn your bridges. If you're struggling with the airway, if you can't ventilate, if the patient is unstable, it's always an option to stop, wake the patient up, and come back another day. Patient safety trumps everything.
That is an absolute masterclass. To our listener out there cramming for their exams, visualize that DLT placement. Rehearse that hypoxia algorithm in a shower. Draw those flow loops on a napkin. You have got this.
Good luck. Walk into that exam. Treat the examiner like a senior colleague you're discussing a case with. Be safe, be structured, and be confident in what you know.
See you in the OT.